It's my great pleasure to introduce a friend and a colleague, Dr. Mike Willard. He's a graduate of Texas A&M University. He did an internship and master's at Kansas State, an internal medicine residency at Michigan State, and after that, Dr. Willard held faculty positions at Michigan State, Mississippi State, and lastly returned to his alma mater, Texas A&M University. He is a noted expert in GI disease and endoscopy. Dr. Willard has given over 3,800 hours of invited postgraduate continuing education lectures nationally and internationally, and has over 80 refereed publications and over 150 book chapters. Dr. Willard will lecture on flexible GI endoscopy, electrosurgery. So Mike, I'm turning it over to you.
Hi, Dave. Thank you very much. Thank you for letting me be here. Actually, this is a video right here. This is a video I took in Indonesia. If it'll get started here. And this was at a wildlife refuge center. These are Sumatran and Bengal tiger cubs, extremely rare animals. And here they look so cute and cuddly. You know, you just want to pick one up and just love on it. I mean, look how cute they are. But even at a young age, they display certain tendencies, right? And the point I want to make, I'm putting this up here, number one, because I like the video, but number two, also, this is a little bit like electrosurgery. It's nice and sweet, but if you don't know what's happening, it can turn around and it can bite you. And I want to focus a lot on some of the problems that can occur. I remember when I first started doing this, it was about 1983 to 84, 85, somewhere in there. And I hate to say it, but I was a bit cavalier. My attitude is, I mean, come on. I mean, if a surgeon can do it, why can't I? I mean, what's the big deal? Well, I found out in a hurry that's the wrong idea. You can make the patient much sicker. You can kill them, and you can destroy your equipment if you don't know what you're doing. This is not something to just play around with. Now, the trouble is endoscopic electrosurgery is part science, but it's also part art. It's just like endoscopy, okay? My guess is some of you find it very easy, intuitive. You think in 3D terms. Other people struggle with it. It's the same thing here. Now, my point is this. I'm going to give you some science, then I'm going to give you some more practical stuff, but the science is important. Simply knowing the science is not going to let you be successful. It's not all you need to know. You've got to have the skill too. But if you know the science behind the technique, it can really help you out when things are not working. And that happens a lot. Now, this is the difference between education and training. Training is when you say, you know, turn left, go up, go down, and that works great as long as everything goes according to plan. I don't know about you, but most of my clinical life things have not gone according to plan, and I've had to figure them out. So that's why we're going to go through some of this stuff. Now, first off, you've got a generator. With electrosurgery, the generator produces a high frequency current, something in the 100K to 4 megahertz range. Now, at this high frequency, it doesn't usually cause muscles to twitch, okay? What it does is it heats up the intracellular contents. All this thing does is heat up the fluids inside the cell. If it heats them up so much that they boil and explode like a pressure cooker exploding, that's called cutting. If they heat up and it just steams off and it gets dry when the steam leaves, that's dehydration. That's called coagulation. Basically, all this centers around the idea of you're removing fluid either quickly or slowly, either a lot or a little, and that controls everything. Now, important point. Generators are not standardized. It's not like every manufacturer has a generator which is the same as everybody else. And this happens in veterinary medicine. This happens in human medicine. You cannot assume that this generator made by company A is going to work exactly the same way as the generator that you're used to from company B. They've had cases of people getting really hurt because a physician goes into an ER and says, oh my gosh, oh, I don't know, I always turn it up to this, and they cause problems. There's several different ones. Now, this is the Storz generator. And by the way, folks, just so we're clear, I'm not in Carl Storz's pocket, okay? I know people at Carl Storz, we're friends, but it's not like I work for them. And I show you this because, now actually, to be honest with you, I like this. This is a simple, basic, elegantly pleasant generator. You know, it's intuitive, it works. It'll be sufficient for like 98 to 99 to 99.9% of what most people are going to need. It's pretty straightforward. Now the trouble is this generator has numbers on it just like this one. This is the one we used at A&M a lot. This is the Valley Lab. Now the Valley Lab is really fancy. It does a lot of things. I can remember spending 15 or 20 minutes sometimes trying to figure out, no, this one, no, okay, wait, okay, on this one we connect this wire here and all this kind of stuff until we finally got an SOP done. It was a lot more complex, and the numbers aren't quite the same as what you would use on the Storts. This is an upper end Olympus generator. This is a flippin' F-22 Raptor. It doesn't look very complex, but I can assure you it took me 45 minutes of reading the manual just to try to figure out what mode I should have it on. And the settings were completely different. So all I'm saying is, number one, you know, if you call person A, what settings do you use? That may or may not work for you, okay? Depending on the generator that you use. You're gonna have to kind of find it out yourself. And the idea is be simple, be safe. Now, one problem which can occur, and this one is admittedly uncommon. I'm just gonna mention it briefly. I've never seen this one, thank goodness. It's called capacitance discharge. Now, this primarily happens when you're using large diameter endoscopes. And what happens is if you have a messy field, you know, like wires hanging over each other, and especially if these wires that are going through the endoscope are also hanging over the insertion tube, what can happen is, well, let me come up here. What can happen is you can have a sudden electrical discharge, just like a capacitor. I mean, like this, and it sends the charge the wrong way. Now, number one, this is a small thing. Very simple, folks. Don't be messy. Don't have stuff hanging over everything. I mean, I doubt you'll see this, but I'm just saying it's reported. It sounds pretty bad. Don't be messy. That won't be a problem. This is a small thing. Now, there are two types of electrosurgery. There's bipolar, which is nice. That's when you have a positive and a negative in the same instrument right next to each other. There's no need for a grounding plate. Now, this is really easy. You don't have to worry about the grounding plate. This is actually a thermal probe. I think this is a Karl Storz thermal probe, if I remember. And you can see here, I just have a piece of wet paper on a table with nothing attached. And if we come up on this, all I have to do is touch it. See? I mean, it's very nice, very simple. These are a little bit more expensive. That's very nice. But the trouble is most of the stuff we're going to use is going to need to be monopolar. Now, monopolar means that you've got an active end, which is what you're sticking in with the endoscope, and then you have to have a grounding plate. You can call it a remote electrode, a grounding plate. It's got various names, okay? But you got to have a ground. Now, we all know this. You've got an electrical, I mean, if you just have something hot out there, electrical, it's not going to hurt you unless there's a ground. Electricity goes to ground, right? We all know that. That's pretty simple, okay? And you'll note that these arrows are about the same size. Now, the point you have, this becomes really important, bear with me. The amount of energy coming into the active end is the same as the amount of energy that's going to be delivered to the grounding plate, the remote, or the ground, okay? It's going to be the same. The same amount of energy is going in both places. Now, this brings up one of the most important concepts, which is current density. Current density is, let me minimize that, is the amount of charge per unit time that flows across a unit area of a chosen crosshair. Basically, what it means is current density is how much electricity do you have going through this area right here, okay? How much? And if we take a look here, if we come back, if in fact the active end and the return end, or the polar, are the same size, guess what? There's the same amount of current, okay? There's the same amount of current. Now, the current density in the remote end, the grounding plate, desperately needs to be less than in the active end. The active end is where you're cutting or coagulating, right? Well, guess what? If your current density at the grounding plate is the same as your current density at the active plate, whatever you're doing up here, you're doing down here too. So what we do is we get around that by having a small active end and a big remote end, okay? I mean, for example, again, take a look. Now here's, you've got a remote, the return electrode's about the same size as the active end. As I start to increase the size more and more, that current gets spread out. I am decreasing the current density. It's the same amount of charge, but in a larger surface area, so that makes it safe. That's why your grounding plates tend to be so big, right? You want big grounding plates. Now let's go back to this idea. What happens if you screw up? What happens if the return electrode is about the same size or gets smaller or something like that? What happens then? Well, here are a couple of publications you might like. This is a 2001 out of Australian veterinary practice where basically they gave one patient a full thickness burn. These were in dogs. Here's another one out of Jaha, 1993, the same thing. They had a dog and a cat. They burned them then. Now, those are just some of the reports they have in veterinary medicine. I guess people don't like to report this stuff in vet medicine so much. In human medicine, it are a big deal. Now, this happens to be from a 2012 publication I've quoted here, or I've cited. This is not bad, actually. I've seen pictures where all the flesh, all the skin is gone. You can look down and see the muscles and the tendons, okay? Can you imagine if you're busy up here doing a procedure and you've forgotten about the grounding plate over here and you're just buzzing away and buzzing away and buzzing away for a long time? It can be bad. There have been humongous lawsuits over this, truly humongous lawsuits. Now in human medicine, to get around this, they have rather fancy grounding plates. This is a typical human grounding plate, and it's really complex. I mean, you've got two different electrodes right here. They're hooked up here. There has to have the same amount of energy going through each one. If something decreases, there's an automatic shutoff valve. This is a big deal. Now, all I'm saying is this. Just because you have the patient sitting on top of a piece of metal doesn't mean you've done the job. There has to be contact. Use lots of electrode goop, and especially with endoscopy. Come on. How many times have you found yourself saying, oh, move him, turn him up a little bit. Maybe I've got a better angle. I tell you what, put him on the other side. As you're moving this patient, you can be changing what's going on in the grounding plate. This can be a big deal. It can be a very big deal. Now also, let's talk about the placement of the grounding plate relative to the active electrode. Can you appreciate that the closer it is, the less tissue is in between the active end and the return electrode, and the less resistance? What does that mean? Potentially less energy is needed, okay? And can you appreciate that as you have more tissue, you have more resistance, you might need more energy. Now, in many cases, we don't worry about that. I mean, come on. If you're working on a 12-pound Schnauzer, what's the big deal? On the other hand, if you're working on a 145-pound Great Dane, can make a difference, okay? So think about the placement of the remote. And more than that, think about what's in between. Now, this doesn't happen as much in veterinary medicine as human, but it does happen. Pacemakers especially. This is a nice little publication out of 2017 where they had 0.3% of all patients had output failure, i.e. the pacemaker quit working, or inappropriately low pacing. 30 beats per minute is pretty low. In another case, they had 3.2% of all of the major problems with their pacemaker were due to electrosurgery. Now, I grant you that may not happen very often, but I mean, seriously, I mean, do you want to be the guy to come up and say, gosh, it happens rarely. I'm sorry it happened to your dog. Not a way to build a clientele. So important points about the grounding plate. Place it relatively near the side of the active electrode if you can. Use lots of conductive gel. Keep focused. The grounding plate must remain in complete contact. That are a big deal. And try to avoid putting things in between that you don't want to get electrified. Now, something which tends to bore people, which helps understand those, the duty cycle. When you've got this electrical current, you know, it's AC, so you know it's going like this. And here you have a duty cycle, and this just shows continual electricity, right? This is called the crest, how high it goes, and there's no space in between the charges. What your generator does is it changes the duty cycle. It can make the crest go higher or lower, and it can change the space between the discharges. Basically, this is a 100% duty cycle. This is about a 10% duty cycle. Here, you get a charge, then it waits about 90% of the time, then you get another charge and another one. Folks, this makes all the difference in the world. This is important. Let's start off talking about electrocoagulation. The way you cause coagulation is you're heating the tissue relatively slowly. Fluid dissipates, then the tissue cools down so it doesn't burst. Then you repeat it, so you keep losing fluid, losing fluid, losing fluid. You're producing desiccation and coagulation. That's hemostasis. That's a duty cycle of 6 to 10%. That's this little picture down here. Now, this is important. Close contact causes more desiccation. And if the contact between the active electrode and the flesh is too tight, or if there's too much pressure, you get excessive desiccation deeper and deeper and deeper into the tissue. I mean, what happens is now you're sitting here and maybe you're saying, oh, Mash, I want to make sure this doesn't bleed. So you just leave it there and you're going bzzz, bzzz. Oops. Oh, sorry, didn't mean to do that. Yeah, bzzz, bzzz, like that. You know, it just goes deeper and deeper. That you're heating things up. It goes in, it goes in, it goes in, and you're desiccating more and more and more tissue. And if you desiccate it too much, you kill it. Maybe you don't break it apart, but you kill it. Here's where you get into trouble. Pure coagulation setting can cause deeper tissue injury than either a pure cutting or a blended cutting. This is where people really get zapped a lot. And especially, once again, if you're nervous or if you're not sure and you're having difficulty and you're pushing that instrument in to get a good tight fit, you're just causing the burn to go deeper and deeper. Now, first point to be made, if you're not sure what to use, if maybe it's the first or second time you've used this unit or it's a new procedure for you, start low. In general, most of the time we're starting in the 20 or 25 range on cutting and coagulation, or coagulation if you're just using coagulation, and work your way up by increments. How do you work your way up? You try it. Oh, it's not working. Let's crank it up a 5. Try it. Is it not working? Crank it up 5. Go slowly. Now, a big thing here is you want continuous close contact. You do not want continuous application of energy. The active electrode stays there, but you don't go bzzz, you go bzzz, 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 something like that, okay? You do not want continuous application. Folks, I'm telling you, this is where you're going to really have problems. This is what's going to cause a lot of difficulty. If you get too much coagulation, if you're lucky, it just causes serositis. It causes some tissue damage, a little bit of death. You get inflammation. You can get fever, leukocytosis, pain, nausea. A little bit more, it's going to kill the tissue. It's going to break down. And when it does, that blood vessel is going to open up. You can get bleeding. This can happen 2 to 8 days after the procedure. Or you can just flat perforate. Okay? You can just flat perforate. Major point. Coagulation is more likely to cause you problems than cutting. Now, this is a not so pleasant story of my own. This is the very first case I ever used electrosurgery on. This was back in the 80s. This is a gastric polyp. It's right at the pylorus. It's causing obstruction. And I was going to take it out. I said, I'm going to take it out with electrosurgery. And the surgeon's saying, oh, give me a break. You're going to screw up and we're going to have to go in and rescue you. I can tell you, it's going to bleed like crazy. Get some blood ready. This guy doesn't know what he's doing. And you know, I really wanted to do the electrosurgery. I sure didn't want to have the surgeons rescue me. So I just said, well, you know what? I'm going to make sure this guy doesn't bleed. And so I hooked up to it and I looked at it and I cranked the coag up a little bit, looked at the surgeons, cranked it up a little bit more, looked at him again, cranked it up more, and there I did. I cut it off. It didn't bleed. What you see there is a burn. This dog vomited worse from the burn I gave him at the pylorus than he ever did from the obstruction for about the next week. I'm lucky he didn't perf. Okay? So this is a good example of what you don't do. It's a perfect example of what you don't do. Now, cutting, on the other hand, is when you have like 100% duty cycle. Here, you're zapping the cell. You're getting it as hot as you can, as fast as you can. The cell, it's just like a pressure cooker. It explodes, okay? Now, the fact is, because it's going to explode, you have to have some water in the tissue. You cannot completely desiccate the tissue first and then cut. If you completely desiccate the tissue, nothing's going to happen, because cutting is where you boil the water in the cell explodes. That's called cutting. You can't completely desiccate it. Now, because there's no desiccation, there's no coagulation, if you're going to use pure cutting, which to be honest with you, I don't think you should. I think it's very rare you're going to use pure cutting. But if for some reason you decide you're going to, you coagulate the tissue first a little bit. Okay? A little bit. Obviously, immediate bleeding is what you're worried about. And if you didn't coagulate it enough and you cut and it bleeds, then you have to go back and, coagulate it. Now, you need to have some tension of the wire against the tissue. But remember how I said this is part science and part art? You need to have enough, but not too much. Remember that concept of current density. When you've got this wire, the deeper and deeper it is in the tissue, the more tissues around it, guess what? You have more surface area contacting the electrode, and you have decreased current density. Your goal is to have a small section of the electrode pushing against the tissue gently. Let me show you. I mean, imagine, now here it's just touching. You have to have a little tension. As I push it in more and more, there's more and more tissue around this wire, you're decreasing current density. And a mistake people make is, oh crap, It's not cutting. I need to push harder. Wrong. Again, it's part science, part art. You need to have it tight enough, but not super tight. Just go slowly. Don't play Hercules. Now this video, this is a cadaver prep. I didn't know the sound was going to come through. I have no idea what it's going to sound like. But anyway, I'm going to show you the difference between between a small contact and a large contact, okay? Now first, I'm just going to have a little bit of the edge right here. I'm going to touch the sample. Look at that. You saw the spark, right? Now watch what happens. I'm going to put a whole large area against it. So there's a lot of wire contacting it and nothing happens. Let's try that again, shall we? Look, little bit, lot. Little bit, lot. Little bit, lot. This is the idea. I mean, sometimes too much is less, okay? You have to have enough contact, but if you have too much, you lose current density. Now, most of the time, I think most people are going to be using a blended coagulation cutting setting, okay? The duty cycle's in the 25 to 50%. And what this does is you're sort of coagulating it slowly. You're sort of exploding the cells slowly. And the whole idea is if you're going to have a blended setting, you're not going to cut as fast. You're not going to coagulate as fast. You've got to go a little slower. Okay, you're going to have to go a little bit slower. When they make the comment, even if you do it correctly, post-polypectomy blading can be seen 12 hours post-procedure. You need to watch the patients because you're not quite sure if you desiccated it too much or something. But in general, if you're blending it, you're going to have to go slower because you're cutting more slowly and you're coagulating more slowly. Now, there are all kinds of probes you can use, folks. I mean, there's just gazillions of probes. I mean, if we take a look here, this is a knife. That's hot biopsy forceps. By the way, this stuff is evil. We'll talk about that. That's a coagulation probe. That's a snare. Most people are going to be using snares, I think. Now, here's the idea. We talk about taking out polyps. Now, this is a nice idealized picture of a polyp. Don't you wish polyps looked like that, actually? Don't you wish they were standing up with a narrow stalk that says, here, take me, I'm yours? No. Well, in general, what you're trying to do is aim for about midway up the stalk or where the stalk should be. First point, do not try to get as close as possible to the base. Do not. Number one, if you're taking out an adenomatous polyp with one of these things, almost guaranteed you're not going to get all of it. The reason you take out a polyp with endoscope is because it's so far in, you can't really get to it by eversion. And you can't really, that's the whole idea. You can't get to it by eversion. You have to go in. It's beyond the point of eversion. Don't try to get it all for a couple reasons. Now, first off, pull the snare snug. Don't pull too tight. You don't want to do a cold mechanical cut. In people, they do cold polypectomies. In fact, that's what they do on me. I know my gastroenterologist pretty well. When we do a colonoscopy, I'm wide awake. I don't take any drugs. I'm kind of watching what he's doing. But people have different kinds of polyps than dogs, okay? Most of the time, they have different polyps. And like I had some like 2 to 3 millimeter polyps, and basically they just put the snare around there, tighten it up, and pop it off. Bleeds a little bit. Don't worry, all bleeding stops eventually. But I mean, that's what they do. But that's not what's going to work for us. We have different kinds of polyps here, right? Now, second, you have to consider the amount of tissue that you're going around. If it's a small stalk, relatively small, you're going to be using less current. If it's a big stalk, you're going to have to be using a greater amount of current, okay? Again, start slow, work your way up. How do you know? I'll show you some pictures in a minute. If you're not seeing any bubbling or steam, nothing's happening, it's too low. Or you're pulling in too tight and you're decreasing current density. Now, in general, what you want to try to do is you want to try to remove the thing that you're cutting up so it's not touching other tissue if it's possible. And that's hard in dogs and cats. This is called tenting. You're pulling the polyp up away so it's standing up. Now, as I said, that's kind of hard, but there's some reasons to try this. First off, when you do the electrocautery, the current's going to go down the stalk. This is where you want to coagulate, right? This is where you want to coagulate. So you're applying slow, steady pressure. You're seeing it bubble. You're seeing it pop. And then you just keep compressing, and pretty soon it falls off. This is what you want to do. Now, if by chance you've got it pushing against other tissue, the current, if it turns out this is a shorter course, the current's going to go this way. which number one means it's not going to coagulate here very well, and number two, it may burn this other tissue over here. So as much as you can, you're trying hard to isolate it. That can be hard sometimes because our patients are smaller. You know, it's so nice to watch a human endoscopy. It's like they're working in, you know, the Holland Tunnel. You got all this space. Try working in a 5-pound dog sometimes. Here's a good example. This is a pyloric polyp. Here I'm pulling it out. Actually, what I did, I don't have a picture. I kind of lifted it up so it was hanging in midair, and we cut it out, okay? That's what you want to do. Now, you really need to think about this. You need to try to make sure you're not touching tissue behind the polyp, because a lot of times we can't see. Now, in the case of gastric I just showed you, that was pretty simple. Because once again, if you're not careful, it's going to take a while to cut this, and you're going to be cutting this in the meantime. Be careful that you know what's behind. Now, a very important point. This is extremely important. Keep the loop away from the tip of the endoscope. You've got an electric current here. It wants to travel to the return electrode. That's its ground, right? Well, you know, the trouble is, but when you're working, have you ever done that? You're working in there and you're playing around, you're trying to get it. Somehow the scope just seems to go closer and closer, doesn't it? You know, sometimes. Actually, we know, an experienced endoscopist knows that panoramic views are much better than close views, right? But you have that tendency. If you get too close and you touch it, the shortest course is going to be going right up your endoscope into your video processor. You'll blow out your LCD, you'll blow out your video processor, and you're going to have a nice long talk with your company rep, okay, about needing a new scope and processor. This is a big deal. This happens. It hasn't happened to me, but this happens. This can also happen if you're not careful and you pull the tissue against the scope. It can go like this, because that may be a shorter course to ground. Now, again, aim for mid-stalk for a couple of reasons. Now, first off, always think about what can go wrong. You know, anybody who's experienced always is saying, what can go wrong? What can go wrong? If it's hemorrhaging, if you cut it and it's hemorrhaging, it would be nice to have something to grab hold of. If for some reason you do get way down here, and now it's bleeding, it can be a little bit more difficult. And besides that, it covers up with blood. Now, this is important because think about it. If I'm coagulating, and all of a sudden there's a bunch of blood, what have I done? I've got a greater surface area. I have decreased current density. Coagulation is going to be less effective. So if we think ahead, in a perfect world, if you were able, if it is possible, have whatever it is you're cutting hanging down. Now, 95% of the time, it's no big deal. Nothing happens. Why are you bugging me? Just wait for that one time when it does. If it's hanging down, the blood's going this way, and you're going to have a cleaner field, and you'll be able to burn it or coagulate it a lot better. This is a good deal. Now, you've got all kinds of snares. I mean, soft, flexible, stiff, rigid. This is a non-slip spiral oval snare. Yeah, right. It slips, but anyway, it doesn't slip as much. You can get whatever you want. But there's something here which is really important. Now, if you take a close look at this, what do you notice? This is braided. This is a big deal. I remember I was in Germany one time, and I was going to show everybody how to take this polyp out of a cat's colon, and I got in there and it wasn't working. Well, guess what? It was a single thin wire. If you know anything about electricity, you know, if you want to carry a lot of voltage, what do? You have multiple wires braided because the electricity travels on the surface. So the bigger the wire and the more wires you have, the more surface area. This is what you want for cutting. You don't want that single slender piece of wire. It needs to be braided. Now, so you're going to use higher energy for thicker stalks, avoid excessive desiccation, avoid polyp contact with the other wall. If possible, have the polyp dorsal to avoid blood pooling. Now, we can talk about a saline pillow later. In human medicine, saline pillows can be very advantageous because people tend to have different kinds of polyps than dogs do. Okay, they can have very different ones. Now, let's take a look at this video real quickly. There's a pylorus, there's a little polyp there. But then you come up here, and whoa, look at that. Now, anybody see the show Jurassic Park? Jeff Goldblum has a line in there that I just love. And the line is, he's talking to these scientists who created the dinosaurs. And he says, yeah, you know, your scientists spent all this time asking if they could do it, but they didn't ask if they should. Now, respectfully, gastric polyps, most of the time, are just innocuous things just kind of sitting there. If they happen to be sitting in the wrong place, they cause obstruction. Dave Tweet might correct me later, or somebody else might correct me, but I think it's very, very, very rare that a benign polyp in the stomach turns into something malignant. I'm not saying it can never happen, but I think it's fairly infrequent. Again, Dave, later, or anybody out there, if you have a different experience, I'd like to know. But yeah, this is a big polyp. This was found accidentally. We were going into the duodenum. We said, wow, this is good. Do I do something with this? If you want to take a biopsy, fine. I would not go cutting on this myself. Number one, it's very big. And number two, I don't think it's doing anything. Okay. Now, on the other hand, here we have an animal that's got lots of polyps, and they're in not the best place. Actually, a few have already been removed at this point. Obviously, we take a look down in the duodenum to make sure there's no big hassle down there. There's not a bunch of stuff down there. Looks pretty clean. There's the papilla. So what are we going to do? First, we're going to find a polyp, and let's find an important polyp, something which is actually doing something. Like down here, close to the, yeah, well, there's one that's already off it. Yeah, down in there near the pylorus. Let's take that one, shall we? This dog was actually having clinical signs. Now, what are we going to do? We're going to inspect it first, make sure I haven't grabbed something I shouldn't grab. And now I'm going to tent it, okay? Now look at that. I'm lifting it up, and I'm keeping it away from the end of the endoscope. I'm applying gentle pressure. Now just watch what happens. You can see something's happening there. There. You can just take a bunch out, okay? That's the way you should like to do it. Now that one's actually pretty simple. This one's a little bit more difficult. Now here we're in the duodenum. We're coming out of the pylorus. And we see something here at the pylorus. Well, I'm looking at that. Well, that's interesting. I certainly need to biopsy this and find out what it is. It doesn't look like it's causing any obstruction at this point. But the trouble is things at the pylorus can sometimes flip in and flip out. That doesn't look like it's causing too much obstruction, but in a second, boom, oh yeah, now that can cause obstruction. It's like a ball valve. And this is going to be a little bit harder. I don't have a lot of space around me, do I? I wish I did, but I don't. So let's go ahead. Now, first we're going to put the probe around. Have to play with it. Take your time. Remember, paranoia is your friend. And we're going to, I think we're going to get around it. Take your time. If you don't like it, let go and grab it again. I'm going to try to bring it forward as much as I can. I can't isolate it entirely, but that's the best I can do. Blow it up with air. Try to get it as far away from everything else as you can. I can't do as much as I want, but now we're going to start applying some electricity. Just watch along that line. Slow, steady pressure. You notice I'm not in a hurry, am I? I'm not in a hurry. And that's not enough. Let's turn up the voltage a little bit more. Let's try this. Oh, there we go. And it was easy to tell that I'd gone through because I was applying so much pressure that I snapped back once I was no longer holding on to it. Now that's kind of what you have to do in cases like this. Now here's a duodenal polyp. This is from a case in Israel. Now take a look at this. I'm looking at this one. This is more of an adenomatous polyp. Now this is going to be difficult. And plus that, we know that adenomatous polyps in the duodenum can bleed like a stuck pig, especially in cats. So this one I would be leery of. Now let's talk about colons, okay? There's a colonoscopy. Now, pretty big one. Now what am I going to do? Well, the first thing I'm going to do is I'm going to inspect it, because remember, I need to know what's on the back side. What does it look like back there? Let's take a look, shall we? Okay, so I got some idea of how far it is. You know, I'm looking at this. There's no way I'm going to grab the whole thing. This is called the piecemeal approach. So try to grab something that you have some good reason to think you're not grabbing something you don't want to grab, okay? When in doubt, take a smaller bite. You can always go back for more. If you take too much, you can't put it back, okay? So we're going to take it here. I know I don't have the whole thing. I just want to take some pieces. I'm going to have to chip away at this piecemeal. And as far as isolating this is going to be hard because this is adenomatous. If I pull too hard, it's just going to snip off, and this is probably going to bleed like crazy. So I can't really pull it out as much as I want. It's about the best I can do. So let's go ahead and let's start applying some energy here. Notice I'm keeping it away from the tip of the scope. There, bingo. I think. Let's take a look a little bit more. Okay, I've got some. Now, normally I'd get that out of the way first, but some more is coming out, so, you know, make hay while the sun shines. If you have an opportunity, we all know this, take it while you got it. You may not get another good chance. And now we're going to go back and take another piece. And we're going to try to take multiple pieces of this. You just chip away on something big like this. Remember, you can always go back for more, but you can't put it back if you take too much. And I'm not going to bore you with this over and over, but the bottom line is we just took out piece after piece after piece. We got most of it out. But again, if we go back to the beginning, look at that. There's no way I'm going to do a complete resection of this. It ain't going to happen. You know, it's not going to happen. It's got too broad of a base, and I would be too dangerous. So I'm going to be able to chip it away and get as much out as I can. So large polyps often need to be removed using the piecemeal approach. Start high, slowly work your way down. And by the way, and this is not so much a problem with the polyp, but make sure you can let go. I have not had this occur with me, but I've had a resident who got a hold of something and couldn't let go, and then the surgeons had to rescue them. Now, a comment, and this is legitimate. If you are up in the colon, watch out for flammable gases. Now, people laugh about this. It ain't funny. I was at a meeting at Mayo Clinic many years ago. This is probably about 35 years ago. And this gastroenterologist was explaining how he was doing this endoscopy. And in this back then, he was just like, okay, bend over, dude. And he's got this scope, and he's going to go ahead and take this thing out. And he hit the spark. And he's, in his words, the next thing he knew, he was back there against the wall. His client or patient had his head in the corner. The guy turns around and says, hey, doc, take it easy. I mean, it happens. Now, I don't think we're going to see much of that because most of the time we're not taking polyps out deep in the colon, okay? But if you do use a lavage solution, again, it probably wouldn't happen. But again, do you want to be the guy to say, wow, you know, I'm going to write this up. This is the first time anybody's seen this on a dog. You don't want that. If you've used a gavage solution and you're in the colon, it might be a good idea to just evacuate, you know, change the air once or twice, something like that. Now, this is kind of a whoopee wow wow. This happens to be an esophageal polyp. This was pretty flippin' weird. I don't know. I'm just showing you that. I mean, most polyps in the esophagus, well, this is actually this is an ectopic thyroid, which is causing a polyp. That's pretty weird. Sometimes you see other things. This happens to be a leiomyoma. This was just trying to debulk it. The same things that can happen here. Okay, fine. Oh, this is not the abdomen. This is the chest. And if you take a look, can you see something right here? That are a mass. Let's talk about airways. Now, endoscopic electrosurgery is primarily indicated for masses obstructing the trachea. Now, there are two good ways to kill your patient with this. The first is hemorrhage, especially if you're dealing with a cat or a small dog. It takes very little hemorrhage to, to go ahead and, asphyxiate. That's the small thing. The super important one is oxygen. You do not administer oxygen. Now, you can be administering room air. Like what I would do is we had an Olympus N180, which is a pediatric gastroscope. You can have your finger on the insufflation button and be putting in room air. That's enough. But if you're putting in oxygen and you hit a spark, you can cause fire. Now, this is a report in Human Medicine, 2007. I just want to show you this. They weren't willing to show what the trachea looked like, but this is the esophageal endotracheal, the endotracheal tube. This is black and melted. I think this shows you why they didn't want to show you what the trachea looked like, okay? They have killed people doing this. This is bad. And, you cannot be using oxygen. No. In fact, this was another paper. This is a 2019 review article. They make the observation that the 4 major procedures in otolaryngology with the highest risk of surgical fires are first and foremost endoscopic airway surgery. This can cause you problems. I'm going to have to change PowerPoint presentations. And while I do, Dave, if there are any questions, I can try to answer those. Let me just change this for a second.
Yeah, Mike, we have one question. And this is from Alan. He says, I use a Megadyne grounding mat. How often should that mat be replaced? and how to test if it's grounding effectively.
Okay, first I'll have to tell you, I've not used Megadyne. So I can't tell you how long it lasts. I just don't know. And I'm not familiar with it. I'm sorry, I can't answer that question. I mean, if it's your regular, I mean, well, if it's just the regular metal plate, that's never going to wear out. I'm sorry, Megadyne I'm not familiar with. I'm not going to be helpful. I apologize. Let me come up here and screen share.
Okay, that's it for now.
Okay, here we go. Now this is an airway. Now you'll note there's no endotracheal tube present because this one's pretty far up, and basically we're just, in this case, we're just insufflating air with the scope. This dog had malignant melanoma, which had spread. Now in this case, this one actually went out fairly smoothly. We're just trying to, I mean, we're not going to cure this dog. We're just going to try and take away some of the nodules so it can breathe a little bit easier and have a little bit more time. Let's just watch what happens here. On the one hand, you know, it's kind of, you don't have to worry about getting too close. You're just going to put it down on top of the trachea. Don't push in, just take it there and then try to lift it up as much as you can. Now this is actually pretty simple because just of the placement of where it is. It's a little bit closer than I'd like to be right there. Let's kind of back off a little bit. I can see my wire back over here. Tighten down. Okay, now we'll start applying some current. Again, we're kind of moving things up little bit by little bit because I'm not sure how much to use here. Again, you notice I'm taking my time. I'm taking my time. I'm kind of going up, also making sure that thing is far away from the tip of the scope. There's some bleeding because this is a larger airway. I'm not so worried about it. I mean, we'll aspirate it out later. Here we go. Slow, steady pressure. Yeah, like that. Now that one's pretty simple, okay? Let's take a look at another case. Now this is a cat, and this is a fungal polyp. And hopefully one of the things you notice right away is there's a lot of blood vessels here. And this is a small airway. Now, obviously we're gonna end up wanting to use an antifungal, but I gotta give this cat some air in the meantime. Now look at this, I was just gonna pass it around, you know, no big deal. Just kind of pass it around and oh my, blood, which is number one, too much will cause obstruction. Number two, it might hurt the current density. Again, the same thing here. I don't have to get it all out. I just have to get enough out so the cat can breathe, okay? And then the antifungal therapy can do the rest. Now, with all that bubbling, I might have had a little bit too much current there, but the thing that happens is, if you'll notice next, this is what it looks like to cough from the inside. You get thrown out. Going back in, because I was mostly worried about the hemorrhage. Now, if we see another one down here, seeing as we're going off on the right side, going down looks like the right main stem, am I going to take that one out? No bloody way. Number one, the cat can breathe better now. Number two, it's going to be hard to know what's on the other side. Now that one looks like that could cause a problem. And especially since this is the airway, if I pull too hard, I can end up ripping it off and causing a lot of bleeding. So that one, once again, discretion is the better part of valor. Now, what about bleeding? You know, sometimes you just get some substantial, I mean, I thought this was rather impressive, actually. In human medicine, they see this from time to time. I've only seen bleeding like this once or twice. And in this case, you know, you want this animal to go to surgery probably, but the trouble is I can't get him to surgery right now and I can't wait. So we're going to have to do something. Fair enough? Now, this is a probe, and the probes come, they can either be just a solid tip or you can have fenestration, not fenestration, but holes up here where you can aspirate, which is really helpful. You can put it down there. If there's a lot of blood, you suck the blood out, and then when you got a good contact, you zap it, okay? So let's take here's an example of what you do. Now, first off, it's going to take me a little while to get it in place. It slowed down for a little bit. Take your time. This is not a race. And by the way, you can tell I'm positioning things, and I'm going to come up here, and you can tell when the juice turns on. 1 Mississippi, 2 Mississippi, 3, boom. Okay, that's what you do. That's quite, now in fact, in point of fact, you know, you could argue that you can also do injections. You can inject absolute alcohol, things like that to stop the bleeding. Because I had electrocautery, I did this. Now, big point. Now that's a probe. Now these are hot biopsy forceps. Friends, do not let friends buy hot biopsy forceps. I bought these things because I thought, well, gee, maybe this would be a good way to get biopsies of some of those really dense serous lesions like serous carcinomas or pitheosis. Well, number one, it's not. This is not meant to biopsy anything. I mean, it burns everything beyond recognition. What this is meant to do is, really what you do is you grab it and then you coagulate it. This causes lots of problems. It is very, very, very common to do too much coagulation and damage the patient when you're using something like this. This are bad. Now, this is another lesion just to show. This happens to be a large inversion. This was a resident who was very excited about doing his first gastric inversion when he was doing a GDV surgery because he, you know, had this necrotic area. So he was kind of plentiful. And you can see all the blood that's in there, and you got this large eroded surface right here. Now, I would just say, why don't you just go in and, you know, cut it out? But they wanted to try to stop the bleeding. I don't know. I think maybe it was going to take a while before they could do the surgery because of the condition of the patient. I don't remember. But here, all you're going to do is, let's just watch again. Yeah, take your time. Again, I know these videos drag out, but folks, again, when all else fails, don't just do something, stand there. Think about it. Yeah, okay, there's a pylorus. I mean, just take your time. Here you can see a little bit more active bleeding. This dog's pack cell was in the 20 range, or maybe it was down even below 20. Here, I'm just going to kind of go across the surface and try to stop it. I'm just going to, you can tell when I'm applying energy. Notice I'm not sitting there going bzzz, I'm going bzzz, 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 stuff like that. And that can be effective. As I said, hot biopsy forceps, not a good idea for polypectomy. You only use it for very, very small lesions. And again, I mean, just don't use it. Don't use it. Now, sometimes we will do electrocautery in the esophagus. Not so much now. We primarily did electrocautery in the esophagus when we had strictures. We were trying to cut them in multiple areas so they break more evenly. I think the BE tube has alleviated some of that, but you might find need for that. Sometimes you got a stricture and you're afraid if you just balloon, it's just going to tear wide open. So maybe you can make some little cuts. So a couple things here. Now, this is a bad stricture, and this is what's called a knife. It's got one wire. Now, this is designed to make a controlled cut. Now, in theory, that works pretty good. But the trouble is, if you're in the esophagus and you want to do this, you want to make like a cut here, a cut here, a cut here, a cut here. So when it breaks, it kind of breaks open evenly. You cannot believe how difficult. Now notice, I'm just doing little bits. Again, I can always go back and do more. You cannot believe how difficult it can be to turn this thing. You'd think I just turned the endoscope. No, it isn't like that. And then when you put pressure on it, it wants to slip back into the groove you made before. I found using this thing was really frustratingly maddening because I was trying to make equidistant cuts. Because of that, I think most people, when they want to cut, if you want to cut the esophagus, what we use is just a regular cautery loop. And this way you make two cuts at once. We just take a look here. I just want to have some pressure against it. Remember, I have to have gentle pressure. And again, I'm using a combined mode, cutting and coagulation. And as you can see, I've got a cut on both sides. Now what I'd like to do, well, then I went ahead, I kind of jumped ahead, but then what I did is I made two cuts like this and two cuts like that. I don't know if that's really that necessary now. I think the BE tube is a real nice thing. Urinary tract, now I will tell you right now, I have no personal experience with electrosurgery in the urinary tract. I'm not the person to talk to here. I do know that if you're in there, you don't want it filled with urine, which conducts electricity. You either fill it with air or better yet with a non-conducting fluid like D5W or sterile water. That's what you would do. But This I can't say much about. Now, so a couple comments. Now, people like to compare human medicine and veterinary medicine, right? Well, first off, there are some big differences. In people, the endoscopic procedure is many times definitive. They go in, we've done it, we're finished with it. In veterinary medicine, sometimes it's definitive. Sometimes you're just buying time till you can do surgery, okay? And so if you know a surgical procedure is coming up, you may say, well, to heck with it, I'm going to resect the area. I don't have to worry about later perforation. Now, if you're not looking at doing a future surgery, then future perforation can be a big deal. In people, most polyps are colonic, and they're usually right colon, which is relatively thin. And you don't find that many polyps down at the rectum. Down at the rectum, you find things like hemorrhoids, okay, in people. Dogs don't get hemorrhoids, lucky animals. So, and also, some polyps are sessile and require EMR, endoscopic mucosal resection. Now, that's not an easy thing, necessarily. In veterinary medicine, I think most of our polypectomies involve the stomach or the colon inside the pelvic canal. And again, I would say if you can just evert it and cut it out that way, that's much quicker, much simpler, much easier, much cheaper, okay? Sometimes we remove respiratory masses. We don't usually see bronchiogenic carcinomas, but we do see some other things. Now let's go back to the saline pillow. If for some reason you're really nervous about this case, maybe it's a very small animal or the location or whatever, for whatever reason, and you want additional protection, what you can do is you can take a needle and you can put a pillow of saline below that. And what that will do, because you know, the tissue goes down to here, what that means is when you cut that out, okay, when you cut that out, you have less chance of perforating. Or if you coagulate it, you have less chance of perforating, okay? Frankly, I don't think you need to do that very often. Happens once in a while, but not very often. Endoscopic mucosal resection, very useful for human colon type 2 polyps, very rarely needed in veterinary medicine. And furthermore, it's not as easy as you might think. You know, in human medicine, the colon is the mucosa is very thin and easy to deal with. You stick some saline in there, it puffs up, and you can kind of put your snare around it, indent it, and cut it out. The stomach ain't like that. If you put a saline pillow there, I mean, I've tried this, and then you keep grabbing it, and the snare just keeps sliding off and sliding off. Even the non-slip snare keeps sliding off. And I haven't really found need for it in the colon, because in the colon, most of the time, the polyps are in the rectum, at least the ones I've had to deal with. In human medicine, these are the different kind of polyps. These are what we consider polyps. These are human polyps. You can have sessile polyps. You can have depressed polyps. This is where endoscopic mucosal resection really starts to come in useful, okay? Things like this. That's why you would really use those. And then basically what it amounts to is you create a pillow like that, and then you put the snare around it. Now, I've kind of rushed. I wasn't quite sure how much time it would take. This is from Chengdu, China. I had a chance to visit the Panda Center there last year. One of the veterinarians at the conference, her father was the chief vet. Giant pandas do three things. They lay on their back and eat bamboo, they poop, and they sleep. They're really magnificent animals, but yeah, that's basically kind of what they do. So anyway, that is the presentation. I tried to leave a little bit of time at the end for questions. I'm not sure, Dave, do I hit stop share or what do I do? I'll say stop.
We've got a couple of questions, and so we'll maybe answer those, and then I guess we're done.
Okay.
But one of the questions is, in most of these cases that you're showing, are you cutting or using coagulation?
I'm almost always using blended. When I took the probe and I was stopping the bleeding, that's pure coagulation. But I think you almost never use pure cutting. Typically you blend, and typically on a Valley Lab generator, which has somewhat similar settings to the stores, I usually start, if it's something small, I usually start with about a 20 cutting, 20 coagulation. That usually isn't enough, and then I just edge it up. If it's something big, if it's a Great Dane with a mass that big, I might start at 30 and 30, something like that. But it's almost always, you almost never use pure cutting, I think. I don't know why you would. You almost always, if you're going to cut, use a blend, cutting and coagulation. That's what I think.
Another question from David is, how often do you use bipolar?
I don't have the equipment. I mean, the only reason I personally would use bipolar is the coagulation probe. For me, that's the only thing it would be useful for. And the bipolar equipment is nice. I mean, you just run it down there, zap it. You don't worry about a grounding plate. It's very nice. For financial reasons, I decided not to invest in it. But if you've got the cash and you're going to do a lot of this, yeah, it'd be a great thing to do. But I did not use it that much.
Okay. Another question is, in airway procedures, if the patient is too small to pass your scope through the endotracheal tube and is becoming hypoxemic, do you tend to immediately pass a red rubber or a small tube to oxygenate them before going back?
Well, it depends on the size of the trachea. Now, if the trachea is big enough, like I said, we were lucky we had an N180, which is a 5.8 millimeter outer diameter pediatric gastroscope. And usually you could get down there and you had enough room between the trachea and the scope that you could just turn the insufflation down low and just insufflate room air. And that gave you plenty of space. And you could do that, and then you could run your probe down, do whatever you needed to. If there was a problem, take the probe out or the snare out, insufflate room air, and that worked very nicely. I think most people know this. I mean, once upon a time, long time ago, I was putting air down there, and the person on anesthesia, I guess I don't know what, we didn't communicate well. Anyway, they cranked up the oxygen too much. We got barotrauma. So I think you've got a better chance of avoiding barotrauma if you're doing it here, because this way you just have the endotracheal tube and nothing else. If you've got the endotracheal tube and a red rubber beside it, you're further occluding the airway, making barotrauma more possible. So I personally would just insufflate through. Now, if the cat was so small, or if the dog was so small that I was afraid to do that, yeah, but respectfully, if the animal is so small that that you're afraid to take a pediatric scope and insufflate air at a low rate through it, that's going to be a rough one, you know? I mean, because you need to take some time to get in there. I haven't had any quite that small, but I suppose if you had like maybe a 3-pound animal, that would be a tough call. I think then you just have to kind of go in and out, in and out. But if you're insufflating through the scope, just be careful of barotrauma. Think about the sizes and think about the flow rates. And then basically it's really simple. You just try it for a while, watch the pulse ox. Yeah, this is working, that's good. Use the lowest flow rate on the scope, that'll work.
Great. Do you always remove all polyps that you have excised, or do you let any pass through the GI tract if you already have the tissue needed for biopsy?
Me personally, I always take out everything. Now again, Dave, I don't know about you personally. I have not seen carcinoma in situ in a rectal polyp. Maybe you have. I haven't, but I'm afraid one of these days it's going to happen. So, you know, I try to retrieve everything myself. I don't know, Dave, what do you think? I'm curious what you would do.
I would, if I've got tissue there and I can get it, I probably would get it.
Yeah.
Try to do histopathology.
Yeah, I think so.
Yeah. If using blended coag cut, then do you hold it down or pulse it?
Well, again, you're going to pulse it, but it depends a little bit. Well, again, it depends on the size. On some of the things you saw that were small enough, I was able just to do continuous, because once again, your coagulation setting is down a lot more. Fair enough? Remember, if you're doing a blended, you're doing less than you would with pure coagulation or pure cutting. So when I'm squeezing, I'll do continuous for maybe 3 or 4 or 5 seconds, something like that. If it's not going, I might stop for a second and then come back and do it some more. Okay. Yeah, but I mean, usually you can go 4 or 5 seconds without much hassle. If it's pretty small, and if you are able to tent it, if you're really able to bring it up, then you're really not that worried. Okay. Again, remember, the problem with coagulation is if you're pushing into the tissue, that's when it's going to go deeper and deeper. If you've tented it up and you got this stalk or something like that, then you have much, much, much less risk.
Okay. What fluid do you use to create a pillow?
Saline. Could be saline.
Okay, Matt has 2 questions. First one is, in regard to rectal masses or polyps, which cases are you generally sending to surgery as the first line approach? And what is your decision for making that process?
If you can evert it, have the surgeons do it. You're going to get the entire polyp because what's going to, if you only get part of the polyp, it's going to come back, right? So if you're able to evert it and do it that way, absolutely, that's the #1 choice. If it's in the middle of the pelvic canal and you can't evert it and you sure don't want to do surgery and split the pelvis, then you need to do endoscopy. If it tends to be further up, which I think is pretty rare, in fact, in my experience, if you start seeing big polyps that are further than the pelvic canal, actually, in my experience, a lot of those are lymphomas. And they're just it's a lymphoma with a it doesn't look like your regular polyp. It's a lymphoma with a fairly smooth mucosa over it. It's not that adenomatous stuff. In that case, what I'm really interested in doing is getting a biopsy and then talking to the oncologist usually. But if it was an adenomatous polyp up past the pelvic canal where you could approach it surgically, what I would probably do is go in first, take off as much as I can, make sure it looks benign, and then you're going to have to decide, what puts the patient at more risk, having the polyp recur and have some bleeding, or doing the surgery and having to go into the colon. I don't know about you, but I really don't like to do incisions into the colon. I really don't like surgical incisions in the colon.
Second question is, what's your experience with reoccurrence in regards to rectal polyps, lesions following electrosurgery, and any follow-up procedures?
I mean, bottom line is, again, if you're taking it out endoscopically, I expect it's probably going to return. Now, it might return in a year or 2 or 3, something like that. But if you don't get it all out, it seems, in my experience, Dave, you may have a different experience. In my experience, it's going to recur.
Yeah, and I think, very easily in the rectum, you can palpate them.
Yeah, absolutely.
In most cases, so you just routinely palpate them.
Yep.
We have one last question, and is that, do you ever use methylene blue to demarcate the layers of the mucosa for your polypectomies?
No, I don't. Actually, the major place I've used methylene blue, I was doing a project with Thomas Spielman, and we were doing endoscopic retrograde cholangiopancreatography in cats. And the duodenal polyp in a cat can be really hard to find sometimes. And we found that if you sprayed new methylene blue, you could see the orifice much better. That helped. But other than that, I don't find that chromoendoscopy has helped us as much. I mean, in people, it's really wonderful. Or actually, they use the different filters on the light, and you can see lesions you couldn't see otherwise. Personally, I haven't found the need for that. Me personally.
Okay. Well, Mike, that ends the questions. Thank you so much for presenting some really great information.
If you said something, I just lost you.
So thanks a lot.
Okay.
Take care, Dave. Said that I learned a lot.
Oh.
Yeah, thanks.
Dave, take care.
Okay. Next week, we're joined by David Zobel, who will speak on lasers and endoscopic surgery. So if you do any endoscopy and you want to expand to interventional endoscopy, this webinar I would encourage you to listen to. So that's Dr. Zobel next Wednesday, August 12th at 2 p.m. Eastern Daylight Time. That's New York time. So wishing you good practice, good health, and looking forward to seeing you next week. Bye.